Be inspired, supported, and empowered. This is the Global Healthy Living Foundation podcast network.
You're listening to Healthcare Matters, the podcast that pulls back the curtain to help you make sense of complex healthcare economics and policy issues. With us is Dr. Robert Popovian in Washington, D.C. He's a pharmacist, an economist, and the Chief Science Policy Officer at the Global Healthy Living Foundation.
Joining me, as always, is my good friend Ben Blanc from the heartland of United States, Indianapolis, Indiana, and our Director of Digital Production and Engagement. Ben, I am sure you've read it in every news article that has come out, both conservative and liberal, about the current measles outbreak in Texas.
I have, Robert, I have. Scary times. Actually, at the time of this recording, there are 223 confirmed cases, with children under 18 making up about 78% of these cases. And interestingly, I did read that in 102 Texas counties, the vaccine exemption rate more than tripled since 2014.
Absolutely. We've seen vaccine rates drop across the country, much more overtly in certain states than others. And the two fatalities that so far have been confirmed due to the measles, one adult and one child, in both cases, they were unvaccinated. They never had received the measles vaccine. So unfortunately, a majority of these cases is with people who have not been immunized. So when people tell me that vaccination doesn't matter, or there's no correlation between vaccination and getting sick, or the worst outcome, mortality, I have to really question their judgment.
Yeah, it all comes down to vaccination policies, doesn't it? And how they impact access. Measles aside, at the end of the day, policies are meant to simplify immunization efforts. But the question is, what happens when they actually make things more complicated? In today's episode, we're diving into a new report which you authored, Robert, on how shared clinical decision-making and risk-based vaccine recommendations may be unintentionally lowering vaccine uptake. We'll break down the findings, explore the barriers these policies create, and discuss practical solutions for improving vaccine access. So let's get to it. Robert, pharmacists and healthcare providers play a critical role in vaccine access, and we actually talked about that in our previous episode. But policies like shared clinical decision-making and risk-based recommendations seem to create added complexities. But before we get into the weeds of this episode, can you start by explaining what shared clinical decision-making is, and also explain the role of the CDC's Advisory Committee on Immunization Practices, also known by its acronym ACIP? Why don't we start here?
So shared clinical decision-making actually came to fruition about 15 years ago for the first time. And at that point, what ACIP and CDC decided to do is to say, look, there are certain vaccines that we're going to leave it up to the healthcare provider and the patient to have a conversation about whether or not it is appropriate for them to be immunized. Look, I'm all about healthcare professionals and patients communicating about what is best for the patient. There's no doubt about it. When that communication happens, that discussion happens, there is a better outcome for all patients. The difficulty with this situation is that this is at the same time that physicians have fewer minutes with patients, where they're much more interested in taking care of, especially chronic disease patients, their other stuff like hypertension and lipid disorder and diabetes and so on and so forth. So to ask them to have a meaningful, long conversation with patients may be a very difficult proposition. And the other thing that you have to also think about is that when we talk about shared clinical decision-making, you need to have a conversation that is both sides are informed about an issue and they come to the table to have an informed discussion. You know me, I've always advocated that patients need to be better advocates for themselves. They need to educate themselves. They need to learn more about their disease and everything else. The unfortunate part is there's so much misinformation today and the last 10 years on the internet that you can almost come to a point that you can find an article or somebody has espoused an opinion that supports your thoughts, whether or not it's correct or not. And that's the difficulty of the situation where you have a very informed individual, like a healthcare professional, physician, pharmacist on one end, and you have somebody who's a patient who should be informed, but is getting their information perhaps from sources that are not reliable, that are coming to have a very informed discussion about a very important issue, which is immunization. And that's been the difficult situation of getting across that point. Now, how do we fix that? Honestly, I don't have a good solution for it because at the end of the day, I am all for consumerization and all about patients being much more aware of their disease and be able to discuss the diseases that they have and concerns they have with their healthcare professionals. But I don't know how do we get to a point that we're arming the patients with information that are from reliable sources and not anecdotes or coming from individuals or organizations that have a vested interest on the patients either getting the vaccine or not getting the vaccine. So that's the difficulty here. ACIP role is interesting because they truly, I believe, they sat back and thought about this when they instituted the SCDM, that it will be a good thing. It will force people to have a conversation. But I'm not sure that they really understood the time constraints and also the asymmetry in the information that is available to patients versus healthcare professionals. And whether or not this discussion would turn into more of a liability where you would see a reduction in vaccinations and immunizations in adult patients. And this is where I think we're going to get into the report and some of the findings that we've discussed in the report itself.
Thanks, Robert. Well, to make things easier, we'll probably refer to shared clinical decision making by their acronym in this episode, SCDM, that is. So, Robert, while the intention behind SCDM was to encourage patient-provider discussions, your report points out that it hasn't necessarily worked as planned, has it? So, can you walk us through the findings in your report about how SCDM has impacted vaccine uptake? Are there any specific vaccines where we've seen a drop in coverage?
Ben, as you know, in our podcast, we always talk about evidence and real-world evidence. We're not about anecdotes and one-offs and things like that. And so I did an extensive literature search to look at studies that have been conducted, to look at whether or not SCDM had an impact on vaccine uptake. And in fact, there are a couple of cases that we can allude to. One, a direct study that was done for pneumococcal vaccine when the recommendation was changed from routine recommendation to SCDM or shared clinical decision making. There was a reduction in adult vaccination, about 10% drop of uptake of pneumococcal vaccine. So that's a specific study that was done and published. The other one, we can do an inference with regards to what has happened in the meningococcal environment, right? So meningococcal Meningitis B vaccine has two different type of vaccines currently, but they're merging the two eventually to have one vaccine only. There's a MenB vaccine, meningitis B vaccine, and then there's the meningitis ACWY vaccine. ACWY meningitis vaccine has been around for decades. The MenB vaccine came out maybe about 12 years ago. ACWY has been routinely recommended as a routine meningitis vaccination for all adolescents. Versus when meningitis B vaccine came out, ACIP for the first time decided to do this, what is called SCDM, shared clinical decision making. They told parents to go talk to their pediatrician or their family physician and their pharmacist to see if it's much more appropriate for their child to have this meningitis B vaccine. What we've seen is that due to the routine recommendation, the uptake of the ACWY is significantly higher. It's about 60.8%, versus in 2022, the meningitis B vaccine was only 11.9% of the adolescents were immunized. So there's not a direct study that was published, but you can look at the routine versus the SCDM recommendation and what the impact is. And I'll give you my own anecdotal thing, and this is where I will talk anecdotes. When the meningitis B vaccine came out, my eldest daughter, was an adolescent. He provided the ACWY vaccine. I talked to him, and this is a pediatrician that has been practicing for at least 2 decades, if not more. And he said, Robert, I don't know about the meningitis B vaccine. They've told us to have a conversation with you all, with the parents. I'm having a conversation with you. Do you want it or not? And obviously, I was much more informed because I worked on this. Obviously, I asked for the meningitis B vaccine, but demonstrated to me the level of confusion that it caused, even for very seasoned pediatricians who have been taking care of children for decades, that going away from a routine recommendation to more of an SCDM without really providing both the healthcare professionals and the patients the tools, the information, and the ability to communicate with one another effectively really undermined the uptake of the vaccine.
Thanks, Robert. And we're talking about SCDM, but SCDM isn't the only challenge, right? Risk-based recommendations also present their own set of barriers. So your report highlights that ACIP's risk-based recommendations can create confusion for both patients and healthcare providers. So can you explain why risk-based recommendations might lead to lower vaccine uptake and what obstacles they pose for providers on the front lines?
We were fortunate enough, Global Healthy Living Foundation, to be provided an opportunity by ACIP committee to testify in one of their hearings. I believe it was the latest one, actually, that took place in 2024. And we provided our input about these risk-based recommendations. And the reason that the risk-based recommendations are difficult is not because healthcare professionals don't understand them. Whether it's a physician, a primary care physician, a pharmacist, a nurse, they understand what these risk-based issues are. The difficulty of the situation is when you are in a community setting, and specifically when you are in a community setting like a primary care physician working in a clinic, or you're a pharmacist working in a retail setting, where most adult patients, and we've discussed this ad nauseum in our podcast, do receive their immunizations, there's not enough information for them to make a judgment whether or not the patient actually has that risk and has that chronic disease that qualifies them for the vaccine. This type of information requires these primary care physicians like working in clinics that are not the main provider of the patient, or pharmacists that most often are providing these type of vaccines to patients who are adults with chronic diseases, to have access to medical health records, to pharmacy records, so on and so forth. And because they just don't have them, it is hard for them to make these judgments in a clinic level or in a community pharmacy level. Now, one of the things that really bothered me with what ACIP did with this risk-based recommendations, besides not thinking through how is this going to be implemented in a community setting without having the full information in front of the healthcare professionals that may be immunizing these patients, is that they said, okay, well, you know what? If the patient walks in and says, no, I attestate and I do say that I do have this chronic disease or this risk-based, then I should be provided the vaccine. Completely undermining healthcare professional judgments. That's like patient walking in and saying, I have hypertension. You need to treat my hypertension without knowing anything about my blood pressure or anything else. You have to take my word for it. This goes against everything a healthcare professional has been taught, which is make sure you first do no harm. So if a patient walks in and just says, I have this chronic disease without any kind of information that the healthcare professional can take a look at, confirm, they're putting not only the patient at risk, but they're putting their own judgment as well as their professional credibility at risk. So I just think I'm not sure what ACIP was thinking in that sense either. Because asking patients just to walk in and say, I have this disease, then why don't we just have it for every other thing? Where a patient walks into a clinic and says, I have lipid disorder or I have diabetes, and you don't need to know my blood level or my cholesterol level. You just have to give me the drug. And it just doesn't work that way in the community. And I think that's also very much a shortcoming of this risk-based decision-making recommendations that were provided by ACIP. So not only the complexity and the lack of data that would confirm this, but also the whole thing of, well, patients will walk in and just confirm that they have this disease.
So we have these well-intended policies, but in practice, just like you mentioned, in some occasions, they seem to make it harder, not easier for patients to get vaccinated. So this actually seems especially concerning for underserved communities. And one finding in your report is that these policies can exacerbate health disparities. So what does the data show about how risk-based recommendations and SCDM disproportionately impact underserved communities?
So let's step back, Ben, and talk about underserved communities, poor patients, right? So they live in communities that probably they don't have access to regular primary care physicians. Majority of underserved communities, patients within those communities just don't see a physician routinely. Let's be honest about it. They probably have much more access to a pharmacy than they do to a physician services, especially physicians that immunize. So in essence, what we're doing is that we are putting them in a situation where they may go to a pharmacy for their vaccines, or they may have to go to a federally qualified health clinic to get their vaccines. And in both cases, because these are not their normal providers, these are not somebody that follows them them, whether it's from a physician level or even a pharmacy level, that they're going to have the information to be able to then confirm that the patient has this risk or has this chronic disease that qualifies them for this vaccine. And without a doubt, whenever you're talking about risk-based decision-making on the behalf of the healthcare professionals, without the healthcare professional having the information to confirm that, it's going to cause exacerbation and under-treatment in a vulnerable population, especially in underserved neighborhoods, because we know those patients just don't go routinely to physicians. And plus, having put all of this aside, because they live in underserved communities, because they probably have jobs that are hourly wage jobs, they just don't have the bandwidth to take off during the middle of the day and go see a physician routinely that may be treating them. And they have to rely on these clinics and these pharmacies to really provide the care for them. So we're exacerbating an already existing problem where these communities are already suffering with lack of access. In addition, we're putting much more burden on these patients to be able to then access very much life-saving immunizations.
So if the goal is to improve vaccine uptake, it sounds like there's a real need to rethink how these recommendations are structured. So you've probably figured what my next question is, Robert. What do you think the new administration may do with SCDM and risk-based recommendations?
All the signals from this current administration is that they're going to double down on SCDM, or shared clinical decision making. They want to have patients to be the judge and the jury and the decider of whether or not they should get the vaccine. This sounds all dandy and great, but we've seen the consequences of SCDM. We've seen in real life what is going on in Texas. And not only Texas, but one of the mortalities actually happened in New Mexico with unvaccinated people or individuals or children. And I believe they're going to double down on this. They're going to make sure that SCDM is the way that adult patients or pediatric patients, even worse, have to decide, and they have to have this shared decision making about their immunizations. And unfortunately, what we're going to see is lower vaccination rates, and we're going to go beyond the threshold that we will have that herd immunity with certain disease areas like measles or mumps and rubella and so on and so forth. And we're going to end up seeing a lot more of these cases. So to be determined, but I believe every time I read something about this new administration and the way they're approaching vaccination is that they want the patient to have the final authority about the vaccines, which sounds great. I'm all about patients' ability to have the final consideration, but there's certain interventions that unless we get a large population of people immunized, then we lose this herd immunity and we will see disease areas like measles and rubella and smallpox and all these things coming back. And then who's going to be liable for that? Is it the patient? Is it the healthcare system? Is it the administration that has made this decision? So that's to be seen in the next few weeks and months.
Well, let's take a step back. Beyond policy, there's also a need to build public awareness and trust in vaccinations. And I know we've talked about this before, but how can organizations like GHLF and other advocacy groups help bridge the gap between policy changes and real-world vaccine uptake? What role does education and outreach play in addressing these barriers?
Clearly, we've seen in the last couple of months since the new administration came to power that there's a movement to not only sort of push the decision to the patient through SCDM type of policies, but also an overt ban of educating patients about vaccination and sharing information with patients. We saw that in Louisiana, where the Surgeon General of the state overtly banned to have any information shared with patients regarding immunization during respiratory season, which is unreal. It's crazy. I mean, the whole intent is to make the patient be the decision maker, and at the same time you're withholding information from them, then what is the point? So I think the role of not only Global Healthy Living Foundation, other patient advocacy groups, provider groups, really is to go back to the basics and start educating patients. And if the government's not going to do it, and the government's going to overtly ban this information to be shared with patients, then it's going to be up to us to be able to push this out to the individuals who come to us for information. And unfortunately, we're in a situation that there's going to be, at the same time that the administration wants this whole mantra about, well, the parents have to make the decisions and the patients have to make the decisions, that they need to know about it. We're going to have transparency and everything else. But on the other hand, they're banning information to be shared with patients, and there's less and less information going out to them. There's no other choice but organizations, whether it's the provider groups, whether it's the patient organizations, that they have to step up and sort of fulfill the the area that the government's not going to do.
And that's a great reminder that policy alone isn't enough, and we also need education, outreach, and advocacy to ensure these recommendations translate into actions. So thank you, Robert, for breaking down this new report, and we'll drop a link to the report in the episode description. So my big takeaway from today's episode is that while SCDM and risk-based vaccine recommendations were designed to improve patient-provider discussions, they have often created confusion and barriers to vaccine access, especially in underserved communities. And to improve adult vaccine uptake, policymakers must simplify recommendations and align ACIP guidelines with FDA-approved indications. But I'm not the expert, so Robert, you have the last word.
I think, Ben, you touched on something very important. I think one of the things that we can do that will help is really go back to the basics and align recommendations with the FDA label. Because the FDA label, we have the gold standard and regulatory body in the world, despite what many people say. And I believe that the FDA label should be the barometer of who should be getting the immunization and what the evidence looks like from a research and development standpoint and regulatory standpoint. The second thing is that if we're doubling down, and this report actually is very timely because it really does talk about SCDM and risk-based decision-making. If we're going to double down as a society and put more onus on patients about shared clinical decision-making about vaccines, whether it's the pediatric patients with their parents or adult patients who have chronic diseases, then we cannot also ban information from going out to them just like certain states have done, just like we discussed about Louisiana as an example. So what we need to do is make sure that somebody is epidemiologically following this information and following the vaccine rates and the disease burden in the next few months, maybe a couple of years, because we are going to see a reduced vaccination rate. We've already seen that prior to this administration coming into power. And I think that's going to be much more dramatic drop in the vaccination rates. And then we're going to see if the disease burden in certain diseases is going to start going up. And so far, that seems to be an outcome that we're observing in Texas with regards to lack of immunization for measles and the outbreak of measles, and we shall see what happens. But I'm not very optimistic because there's one thing to say that you're going to push the decision to the patients and you're going to be transparent about stuff and everything else, and at the same time, you're banning information during respiratory season for health departments to share information with vulnerable patients about vaccines.
All right, Robert. Well, we'll see what the future holds. And that's a wrap for today's episode. Don't forget to subscribe to our podcast on Apple Podcasts, Spotify, or wherever you might be listening so you never miss an episode. And if you have a second, help spread the word by rating our podcast, writing a positive review, and sharing with your family and friends. It'll help more people like you find us.
And if you have any questions, thoughts, suggestions on any of the topics that we discussed, please reach out to us. And we're only going to resolve these policy issues through actual discussion and agreement or disagreements. But they have to be transparent, they have to be open, and you cannot have bans and even mandates that come down. And believe me, I think mandates are as bad as the bans that are going on regarding immunization. So please reach out to us at podcasts@ghlf.org, and we'll bring you on and one of our upcoming episodes.
And before you go, make sure you take a listen to some of our other great podcasts on the GHLF Podcast Network. You can find all of GHLF's podcasts at ghlf.org/listen. He's Dr. Robert Popovian.
He's Ben Blanc. We'll see you all next time.
Be inspired, supported, and empowered. This is the Global Healthy Living Foundation Podcast Network.